We've already discussed enough on the basics of the immune system. Now we are going into the core medicine and hematology topic, that is the lymphomas. Especially this particular video on lymphomas is really important because I'm not only going to discuss the basics as the video name suggests, it's not only the basics, I'm going to give an overall brief idea on what a lymphoma is and what are the markers and how will you differentiate different types of lymphomas, classification and their algorithms to diagnose by immunohistochemistry. All these things we're going to see in this particular video. So with this we'll kick it on. Before going into the different types of lymphomas, it's better to understand what you mean by the term lymphoma and how will you differentiate from the term called leukemia. That's what you have to understand. In one way, you have malignant cells obviously. If these malignant cells are circulating typically, for example, I'm going to take certain malignant hematopoietic cells. If these malignant hematopoietic cells are going to circulate in the blood or predominantly seen in the bone marrow, that is a primary lymphoid organ. So I'm going to call this particular patient is suffering from a leukemia. But the same malignant hematopoietic cells, if they are circulating, not circulating exactly, but if they are sequestered in the lymph nodes or the secondary lymphoid organs, not the primary lymphoid organs, the secondary lymphoid organs, I'm going to call that as lymphoma. As simple as that, isn't it? The best example is coming from ALL, where ALL can be leukemia or ALL can be a lymphoma also. You're going to call it as acute lymphoblastic leukemia or acute lymphoblastic lymphoma, depending on where the malignant cells you're seeing. If the blastic cells or the blastic malignant cells that you see in ALL, if they are circulating in the blood predominantly, you're going to call it as acute lymphoblastic leukemia. If the blastic malignant cells, lymphoid malignant cells, that if they are seen predominantly in the sequestered within the lymph node, we are going to call it as acute lymphoblastic lymphoma. That's it. But both are malignant blastic hematopoietic lymphoid cells only. Second example comes from CLL and SLL. Suppose if your malignant cells, it's a mature B cell, CLL is a mature B cell neoplasm, not a blastic neoplasm. If they are circulating in the blood, these neoplastic cells, if they are circulating in the blood, we are going to call it as chronic lymphocytic leukemia. The same cells, same genotype, phenotype, markers, everything will be the same. The same type of cells are predominantly sequestered within the lymph node. I'm going to call it as small lymphocytic lymphoma. That is why in textbooks they will not give CLL and SLL separately as two topics. They will write as CLL, SLL and they'll give as a single topic only. Please do understand. So this is the difference between lymphoma and leukemia. And remember, there is a lot of areas where lymphoma can get transformed into leukemia. Very simple. So that is possible because the malignant cells that are sequestered within the lymph node might come out of the lymph node and enter the blood and infiltrate the bone marrow at any point. So a lymphoma can anytime get transformed into a leukemia. Often, especially in high-grade lymphomas, this is very common. So with this basic understanding of what you mean by a lymphoma and leukemia, let us move on to what are the differences between the classical types of lymphoma, that is Hodgkin lymphoma and a non-Hodgkin lymphoma. This is how you classify a lymphoma into a non-Hodgkin group and a Hodgkin group. If you ask me the origin of this malignancy, where they originate from, Hodgkin lymphoma typically originates from a B cell, very important. It's a crippled B cell, which I'll tell you the exact origin in the next slide, but it's the B cell that is the most important for Hodgkin lymphoma. For non-Hodgkin lymphoma, the cell of origin can be either a B cell or it could be a T cell. As I already told you in multiple times in the previous videos, the B cell is the most prominent cell type to be involved in non-Hodgkin lymphoma. In 85% of the cases, it's going to be a B cell neoplasm, and only 15% of the cases is going to be a T cell neoplasm. So which means the B cell neoplasm is the most common. And if they ask you overall lymphomas, most common is also B cell only. 85-90% of the lymphomas overall, even including Hodgkin, is B cell only. It's not T cell. T cell is very rare to get. And what is the neoplastic cell here? There is something called a Reed-Sternberg cell. This is called Reed-Sternberg cell. So this is a neoplastic cell in a Hodgkin lymphoma and it's going to be seen. And you don't encounter this Reed-Sternberg cell in a non-Hodgkin lymphoma. This is one of the major differences. And the age group that is affected in Hodgkin, non-Hodgkin, typically in Hodgkin it's approximately 30 years, even though it's biomoderate distribution. Average age that is affected is 30 years, whereas approximate age that is affected in non-Hodgkin lymphoma is around 60 years and above 60 years. Clear? There are a lot of non-Hodgkin lymphomas and leukemias that arise in a younger age also, like Burkitt lymphoma, but in general non-Hodgkin lymphomas arise at an older age, 60 years and plus. And what are the lymph nodes that are involved? Typical lymph nodes that are involved. Remember, the most important thing to understand is this: the lymph node groups that are involved. Remember, Hodgkin lymphoma typically involves only supradiaphragmatic nodes. It's very rare to involve infradiaphragmatic nodes. In that supradiaphragmatic nodes also, the most common that will be involved is the cervical group. Cervical is the most common group to be involved, followed by your supraclavicular group, and they can involve mediastinal lymph nodes also, plus or minus mediastinal. So it's very rare to involve nodes below the diaphragm. That's why I told you these are the commonest group of nodes that are involved. But whereas in a non-Hodgkin lymphoma, it can be either supradiaphragmatic or infradiaphragmatic. Both can be involved in a non-Hodgkin lymphoma. Remember, even in a non-Hodgkin lymphoma, supradiaphragmatic is most common. Even that supradiaphragmatic cervical lymph node involvement is the most common. Clear? Which means both in Hodgkin as well as non-Hodgkin lymphoma, the most common group of nodes that are involved is cervical group of nodes. That is why in any lymphoma, whether it's a Hodgkin or a non-Hodgkin, if somebody asks you what are the group of nodes that are involved, commonly you have to answer it's a cervical group of nodes. And other important points about this lymph node involvement in Hodgkin lymphoma is that these patients will have contiguous anatomical spread. They will have a contiguous anatomical spread, which means one after the other, one by one, the next anatomical site will be in cervical, axillary, mediastinal, like that they go in a very contiguous spreading fashion. Whereas in a non-Hodgkin lymphoma, it tends to be more often a non-contiguous or a discontiguous spread, which means they need not involve like anatomical sites in a sequential fashion. They might involve cervical and para-aortic nodes also. All are possible. And remember, most of the time Hodgkin lymphoma is confined within the nodes, which means most of the times it will be a nodal disease only. Whereas in a non-Hodgkin lymphoma, many times there will be nodal as well as extranodal involvement of the nodes of the disease. So in that they will ask you what is the most common site for extranodal involvement. If they ask you, answer must be it is bone marrow and GIT. But single best answer will be the bone marrow. Bone marrow will be the most common extranodal site to be involved in a non-Hodgkin lymphoma. And extranodal site is very rare in case of Hodgkin lymphoma to happen in the first place. And there won't be any involvement of two important things. One is the Valdes ring, and second one is the mesenteric nodes. You don't involve this Valdes ring and the mesenteric nodes in case of a Hodgkin lymphoma. Very important point. Multiple times asked question. No Valdes ring or mesenteric node involvement, whereas both can be involved in a non-Hodgkin lymphoma. Mesenteric node involvement as well as Valdes ring involvement is common in case of a NHL, non-Hodgkin lymphoma. So these are some of the important things about the lymph nodes. And if they ask you about the consistency of the lymph nodes, consistency is actually not very important, but let us see. Typically tends to be firm and tends to be rubbery in nature. The lymphomas usually, this India rubber consistency is often said to be for Hodgkin lymphoma, but in general the rubbery consistency and firm consistency of lymph nodes in exam generally goes towards the lymphoma. Even though don't use this type of consistency based clinical findings and all for diagnosing a lymphoma, it most often gives you a wrong impression. So only for exams these things and all work. At the same time, in lymphomas, the nodes generally tend to be non-tender. They won't be tender. Very important point. Tender nodes usually go towards infection. It will be generally a non-tender node. That's very typical of a lymphoma. And finally, what will be the lung involvement? Lung is an organ involvement. Lung involvement typically seen in approximately 10% cases of Hodgkin, but very rare. Approximately 30% cases in case of a non-Hodgkin lymphoma. Similarly, treatment-wise, I am not giving the entire treatment because treatment is completely different for Hodgkin as well as non-Hodgkin, and each and every different subtype of non-Hodgkin has different types of treatment, and it's completely out of the scope of the current lecture. So overall, the treatment what we are going to give for Hodgkin lymphoma is the classic ABVD regimen plus or minus radiotherapy. So we'll discuss what do you mean by ABVD regimen when we are discussing about the Hodgkin lymphoma. Till then, be a little bit patient. And non-Hodgkin lymphoma, we are going to classically give R-CHOP plus or minus methotrexate in case if the patient is having CNS disease. If CNS involvement is suspected, usually we give a methotrexate also as an additional therapy along with the R-CHOP regimen. R-CHOP is the commonest regimen used in a non-Hodgkin lymphoma. Usually radiotherapy is not effective for a non-Hodgkin lymphoma, whereas it is very often given in case of a Hodgkin lymphoma, but never in case of a non-Hodgkin lymphoma. Usually it will not be effective. And these are the basic differences. And prognosis we didn't talk about. So what will be the prognostication? Prognosis between non-Hodgkin and Hodgkin. Prognosis tends to be excellent for Hodgkin lymphoma, and the most important prognostic factor is the anatomical staging. Anatomical staging is the most important prognostic determining factor in a Hodgkin lymphoma patient. Whereas here, prognosis is highly variable depending on whether the lymphoma is indolent or aggressive. Depending on that, the prognosis will be completely variable in case of non-Hodgkin. At the same time, anatomical staging in case of a non-Hodgkin lymphoma is not that important. That is not going to give you the prognostication very clearly in case of a non-Hodgkin. All these are really, really important points to understand. And remember, non-Hodgkin lymphoma as well as non-Hodgkin lymphoma, one important clinical feature we didn't discuss. Both Hodgkin as well as non-Hodgkin lymphomas can result in certain characteristic set of symptoms called B symptoms, which are very common. B symptoms. What do you mean by B symptoms? B symptoms is defined as fever more than 38 degrees Celsius. You will have night sweats, also referred to as drenching sweats, so much of sweating you will have. Along with it, you might have weight loss. Typically, very significant weight loss of at least more than 10% of the weight will be lost in 6 months. So significant weight loss, fever, night sweats, all these things give rise to a characteristic B symptoms in a in any lymphoma. It's typically described in a Hodgkin lymphoma, but it depends. What are the B symptoms and what are the percentage of B symptoms that these patients might have. Suppose if you ask me the percentage of the B symptoms typically tend to be present in 35% of the cases of 35% cases in case of a Hodgkin lymphoma, whereas it tends to be variable 15 to 50% in case of a non-Hodgkin lymphoma. Generally, presence of this B symptoms itself indicates a relatively poor prognosis. I'm not telling exactly only poor prognosis, relatively poor prognosis, especially for a non-Hodgkin type. Presence of these B symptoms will have a relatively poor prognosis. So it will run in 35% and 15 to 15% in case of a Hodgkin, non-Hodgkin lymphoma respectively. And typically this fever has one characteristic type called a Pell-Epstein type of fever. This is a recurrent fever that happens, Pell-Epstein type of fever, where this is very characteristic of a Hodgkin lymphoma and seen approximately 10 to 15% of the cases. This is very characteristic. Around 10% to 20% of the cases of Hodgkin lymphoma may have this characteristic Pell-Epstein type of fever, where the fever will slowly rise for a variable period of time and they'll reach a peak and a plateau and they will stay there for some time, and again the fever drops and they will come back to the baseline and they will be afebrile for a variable period of time, and again they will get the fever that is increasing and becoming a plateau, so that they will go up and down like this. So which means you can see it's not a type of continuous fever in case of Hodgkin lymphoma. It's a type of intermittent fever. It's a type of intermittent fever. Why you call intermittent fever? Because if you take, this is the temperature baseline, that is 98.6 degree Fahrenheit or 37 degrees Celsius. You can see the fever often touches the baseline. Whenever the fever touches the baseline, we call this intermittent fever, and we are not going to call it as a continuous fever. The fever doesn't touch the baseline only, we will be calling it as continuous fever. So this is a intermittent fever, right? So since it's an intermittent fever, this Pell-Epstein type of fever can also be put under a type of fever called recurrent fever. So where the fever comes again and again, fever recurs. So in between the patient will have afebrile periods also. So this is what we define as classically. This also sometimes resemble your undulating fever that is seen in brucellosis and all, or relapsing fever seen in brucellosis. But anyway, this is given a special name for Hodgkin lymphoma, that is called a Pell-Epstein type of fever, where fever slowly rises over a period of time, maybe over 2 or 3 days, and reaches a plateau, and again it will remain the plateau and patient will be febrile in the same temperature will be there for another 2 or 3 days, and the fever slowly resolves down and reaches the baseline, and the patient will be, and again that will be happening over a period of time, maybe 2 or 3 days, and again patient will be afebrile for again a variable period of time, maybe 3 or 5 days, and again they will start getting fever again. So this type of pattern, which typically resembles sometimes an undulating pattern seen in brucellosis, is what we refer to as something called a Bell-Epstein fever if it happens in a Hodgkin lymphoma. So all these things are very important to understand about the differences between a Hodgkin lymphoma and a non-Hodgkin lymphoma. Then you have very important diagnostic staging. So how will you make a diagnosis of a lymphoma? Remember, the key is the pathological diagnosis. You cannot make a diagnosis of a lymphoma clinically. Very important. The most important key for diagnosing a lymphoma is pathology only. For pathological purposes, I need to do excision biopsy only. Excision biopsy is the one that is preferred than FNAC. I told you this point multiple times in the previous videos. To diagnose a lymphoma, I need excision biopsy. FNAC and aspiration of a lymph node is inadequate for diagnosis of a lymphoma. Very important point to understand. So typically, alternatively I can do a true cut biopsy also. And the biopsy material should be sent for histopathological examination. You have to also go for IHC. It also has to be sent for cytogenetics. If you do all these three things only, you can confidently diagnose a lymphoma. Sometimes if you miss any one of them, there is a possibility that lymphoma might be missed. Or the cytogenetics and all is very important. IHC and all very important for prognostication also, which we'll discuss later on. So all these things are very important aspects of biopsy on a lymph node in a lymphoma patient, the suspected lymphoma. You can do a bone marrow biopsy. Suppose if there is a suspect of bone marrow involvement like extranodal disease. Suppose if you are suspecting extranodal disease, patient is having a pancytopenia with a leukoerythroblastic picture, then you can suspect a lymphomatous infiltration of the bone marrow. So in that case, you can do a bone marrow biopsy also. Or if you are suspecting a primary leukemia causing lymph node enlargement, then actually lymph node enlargement in leukemia is quite rare. But if you do suspect leukemia causing a little lymph node enlargement, then in those conditions you can do additional bone marrow biopsy also to diagnose the leukemia part. And to diagnose extranodal disease in a lymphoma, where bone marrow I told you is the most common site for extranodal disease in a lymphoma, again you can do a bone marrow biopsy. Then you can do a lumbar puncture, LP, and you can do a CSF analysis. Suppose if there is a suspected CNS involvement. Suspected CNS involvement is there, means then you can do a lumbar puncture and CSF aspiration also, CSF analysis also. Then finally, you have very important current modality. We do something called PET-CT. FDG PET is very common modality utilized nowadays, especially for staging a lymphoma. PET is very important, especially nowadays, rather than the CT scan which has been used previously, nowadays many, clinicians prefer using and hematologists prefer using PET-CT as a primary modality for staging of a lymphoma. Very important point again. Because especially if you know this staging PET-CT, and because this PET-CT is going to help in anatomical staging, isn't it? So this anatomical staging I told you is very important for Hodgkin lymphoma. That is the reason PET-CT is given a lot of importance for Hodgkin than non-Hodgkin lymphoma. Because this anatomical staging has an important prognostic value in case of a Hodgkin than a non-Hodgkin lymphoma. Non-Hodgkin lymphoma is more often, the prognostication is through cytogenetics and IHC. The markers are the ones that are going to tell the prognosis in case of a non-Hodgkin lymphoma. Whereas the anatomical staging is going to be of hallmark and absolute importance in case of a Hodgkin lymphoma. Remember, nowadays this is what is preferred ahead of the CT scans. Clear? The contrast CT and the plain CT is what we have been studying when I used to study in my undergraduation. But right now everything has changed. Now everything is inclined towards doing a PET-CT also. And CT of the head might be needed only if you have neurological symptoms or you suspect some blastic collection causing metastasis-like appearance in the head. That's very rare in general, but in that cases you can do a head CT for confirming or ruling out the disease also, other diseases also. So that is why you do head CT. Apart from that, this PET-CT is the most important investigation as of now for staging, especially for Hodgkin disease. Now, how will you stage a lymphoma? Staging of the lymphoma, currently what we use is something called Ann Arbor staging. everyone knows that, because any undergrad who's studying pathology textbook will know this Ann Arbor staging, but we use with something called Cotswolds modification. Cotswolds modification. So that's what we use. This can be used for both, Hodgkin as well as non-Hodgkin, even though it's more important for Hodgkin than non-Hodgkin, but it can be used for both Hodgkin as well as non-Hodgkin. Apart from the Ann Arbor, what are the other staging systems you have? You have something called the Lugano staging, and you have something called TNM Paris staging also. So this Lugano staging and TNM Paris staging is more important for primary gastrointestinal non-Hodgkin lymphomas. Primary GI NHLs, this Lugano and TNM Paris may be useful, but apart from that, this Lugano and TNM Paris is not that much used in case, for the purpose of staging a lymphoma. We typically use the Ann Arbor staging for lymphoma. If you ask me what is the Ann Arbor staging, let us see with the help of a diagram. So how will you find, what do you mean by Ann Arbor staging with Cotswold modification? So you can see this diagram. So where if you call it as a stage 1 disease, you can tell it's only a single lymph node or a region. It's a single lymph node or a single region, bar region. So you can see only one lymph node region or only one lymph node is involved. So this is what we refer to something called stage 1. In stage 2 disease, if you ask me, there will be at least 2 lymph nodes will be involved or 2 lymph node regions will be involved, but that will be on the same side of the diaphragm. Same side of diaphragm, which means it will be either supradiaphragmatic or it can be infradiaphragmatic. But typically supradiaphragmatic is very common. So in this example, you are seeing only supradiaphragmatic on only one side of the diaphragm, or it could be only infradiaphragmatic also, but that's rare. Supradiaphragmatic is common. In stage 3, you can see disease in multiple areas, that is both super as well as infradiaphragmatic. You can see, which means on both sides of the diaphragm you are having the disease. So this is what we refer to as something called stage 3. And in stage 4 disease, it's a disseminated disease. Disseminated disease, typically they will involve extra lymphatic organs, extra nodal organs like spleen, liver, bones. This stands for pelvis, bone marrow. So spleen, liver, bone marrow involvement, all these things are external disease. Remember, in this condition, the lymph node involvement is only optional. Even if the lymph node involvement is not there, and if you have only extra lymphatic disease, or extra nodal disease like liver, bone marrow, spleen involvement, you can put under stage 4 disease. Any extra nodal involvement will come under, and disseminated disease will come under stage 4 disease only. Typically, remember, this involvement of spleen is very important to understand, because involvement of spleen in case of Hodgkin lymphoma is considered as a nodal disease only. Clear? And involvement of spleen in a non-Hodgkin lymphoma is considered as an extranodal disease. So these are the two things that's very important to understand. Remember, involvement of the spleen in a Hodgkin lymphoma is typically a nodal disease only. Involvement of a spleen in case of a non-Hodgkin lymphoma will be considered as an extranodal disease only. So the spleen only is a little bit controversial which you have to understand. And if they ask you what is the definition of extranodal site, because stage 4 means you are going to involve extranodal and extra lymphatic organs. So what do you mean by, typically you mean by extranodal? Extranodal means it doesn't involve lymph nodes, any other structure apart from thymus and pharyngeal Valdes ring, the lymphatic ring in the pharynx. That's what we refer to as Valdes ring. So involvement of the lymph node, thymus, Valdes ring, all these things will come under nodal disease only. Anything apart from these 3, we call it as extranodal disease. Typically, remember, spleen, I told you there is a controversy. I told you for Hodgkin lymphoma it's a nodal disease, whereas non-Hodgkin is considered as an extranodal disease. But remember, any other organ system or any other areas involved apart from this lymph node, thymus and your Valdes ring is considered as an extranodal disease only. Spleen only is something controversial. Not controversial, it's something little bit confusing. But apart from that, lymph node, Valdes ring and thymus will come under nodal involvement only. Anything apart from these organs we call it as extranodal. Spleen alone, Hodgkin it is nodal, non-Hodgkin it is extranodal disease. Apart from that, there are some modifiers that you have to know. If they put A along with a particular stage, which means there are no symptoms. If they put B along with a particular stage, for example, they put 2B or 3B like that, so B indicates presence of B symptoms, which itself indicates a poor prognosis. And if they put X along with a particular stage, like 2X or 3X or 4X, it means it's a bulky disease. What is the definition of bulky disease? If your mediastinal mass, for example, typically it is useful for mediastinal masses. If in the mediastinal mass, if you are having a lymphoma causing a mediastinal lymphadenopathy and a mediastinal mass, if the diameter, for example, if you see this is the chest in the patient and this is the diaphragm, if you see the chest and if you are seeing a mediastinal mass like this, if the greatest transverse diameter of the mediastinal mass, so first I am taking the greatest transverse diameter of the mediastinal mass and I am going to take a transthoracic diameter or a maximum diameter of the chest wall. Suppose if this mediastinal diameter, the mass of the mediastinal transverse diameter of the mediastinal mass, if it's more than 1/3 of the transverse diameter of chest wall, more than 1/3 of the transverse diameter of chest wall in chest X-ray. So this is one definition of bulky disease. If the diameter of the mediastinal mass, if it's more than 1/3 of the transverse diameter of the chest wall itself, so that is what we refer to as something called bulky disease if it comes to the chest. In infradiaphragmatic, any mass in the abdomen whose transverse diameter, if it is more than 10 centimeter, then we call it as again like bulky disease. So more than 10 centimeter in the abdomen or more than 1/3 of the chest wall diameter, if the mass is involved, transverse diameter, then we call it as bulky disease. So this is the definition of bulky disease. E stands for single contiguous extranodal site. Single contiguous extranodal site, that's what E stands for, which means only one extranodal site, that too contiguous. For example, from mediastinal to lung. These are contiguous but extranodal site. Lung is an extranodal disease. So single contiguous extranodal site is involved, then we call it as E. Then liver involvement we call it as H, that's hepatic. Splenic involvement we put separately a modifier in the form of 2, S, like 2S, 3S, 1S. Splenic involvement is there. So that will be put under separately as S. Hepatic involvement will be putting under H. Clear? So H. So these are some of the modifiers that you have to add along with the numbers of the stage that you give generally. Stage 1, 2, 3, 4. This is a very important staging to understand, Ann Arbor staging. Especially they will ask you the various stages and the definitions of how you stage these diseases. Do you understand? So now you know that these are the different staging systems. But before going there, let us see how will you classify a lymphoma. What are the morphological patterns on how to classify a lymphoma, and the morphological patterns also we are going to discuss. So first, for classifying a lymphoma, we have to know two things. One is what are the different types of lymphomas. I can tell two things. First of all, a lymphoma have something called a B-cell lymphoma, and second thing, you also have something called a T-cell lymphoma. And in this case, we are only going to discuss on the mature B-cell lymphomas. We are not going to discuss on the blastic lymphomas, that is ALL and all, that we are not going to discuss in this particular section. So we are only going to discuss on the mature B-cell lymphomas. And similarly, we are only going to discuss mature T-cell lymphomas. 85% I told you are B-cell and only 15% are T-cell lymphomas. And we are not going to, in the sense I'm going to classify a non-Hodgkin type, not a Hodgkin. That I should have told in the beginning itself. This is a non-Hodgkin type of lymphoma. Mature B-cell lymphomas and mature T-cell. In the book they would have given mature T-cell or NK cell neoplasms. Anyways, fine. So these are how you differentiate. What are the important lymphomas that you have to know for exams in a mature B-cell lymphoma? Number one, let us see something called a Burkitt lymphoma. And number two, you have something called DLBCL, that's called a diffuse large B-cell lymphoma. Third one, you have something called a mantle cell lymphoma. Mantle cell itself, you have an ordinary mantle cell lymphoma and a blastoid mantle cell lymphoma. So many things are there, but let us assume an ordinary mantle cell here. Then you have something called a marginal zone lymphoma. Marginal zone lymphoma is again having multiple types, like maltoma also comes under marginal zone lymphoma. Then you have splenic marginal zone lymphoma, nodal marginal zone lymphoma. So much of marginal zone lymphomas are there. Number 5, you have something called hairy cell leukemia. Hairy cell leukemia. Then you have something called a follicular lymphoma. And finally, you have something called a CLL or a small lymphocytic leukemia. CLL, chronic lymphocytic leukemia, or a small lymphocytic lymphoma. So I told you CLL and SLL are same entity. If it's predominantly seen in the blood, then we call it CLL. If it's seen in the lymph nodes predominantly, we are going to call it as SLL. That's all. So these are the different types of lymphomas that you have to know. These are the things which we are going to discuss in detail. Apart from that, you have primary effusion lymphoma. Then a lot of other varieties of lymphomas are there in the mature B cell neoplasm cell. That itself is a huge topic. We are not going to discuss much. In our subsequent lectures also, we are going to discuss only about these lymphomas in detail, which are very high yield for the exams. And remember, I have placed in decreased order of aggressiveness. Decreasing order of aggressiveness, that's in on that order only I have placed, which means the Burkitt's tend to be the most aggressive malignancy among all the lymphomas. See, I'm not talking about ALL. Blastic lymphomas and leukemias are even more aggressive, but among the mature B cell neoplasms, your Burkitt's lymphoma tend to be the most aggressive. Clear? And one of the most indolent are this follicular and CLL. The CLL and SLL tends to be the least aggressive or the most indolent type of tumor, which means it's not aggressive at all. That's what it means. So then we have this T cell neoplasms, or T cell or NK cell neoplasms in the non-Hodgkin variety. T cell or NK cell neoplasms you can differentiate into 4 groups of diseases. One will come under the cutaneous group. Second one, you have something called an extranodal group. And the third one, you have a separate group of disease called nodal group. And the fourth one, you have leukemic group. This is how you classify the T cell neoplasms. Even though we are not going to discuss much about these T cell neoplasms, it's better to know the classification at least. Cutaneous group, you have 2 types. One is called a primary cutaneous lymphoma. Usually this primary cutaneous lymphoma will be CD30 positive. This is called CD30 positive primary cutaneous T cell lymphomas. And you can write primary cutaneous T cell lymphomas, but I didn't write that. You can simply remember as primary cutaneous lymphoma or primary cutaneous T cell lymphomas. And then you have mycosis fungoides and Sézary syndrome. Mycosis fungoides and Sézary syndrome. It's again the difference between whether it involves only the skin or leukemic cells is seen in the blood also. Depending on that, you can tell both are the same entity. If you see leukemic cells in the blood, then you call Sézary syndrome. If you see only in the skin, that disease is called mycosis fungoides, but both are formed by the same type of cell and same malignancy only. Extranodal, you have some important diseases. Extranodal, number 1, you have NK or T cell nasal type lymphomas where they involve the nose predominantly. Then you have something called enteropathy associated T cell lymphoma. Typically, these enteropathy associated T cell lymphomas happen in gluten hypersensitivities and all, in celiac disease especially. Then you have something called hypersplenic T cell lymphomas. Then you have subcutaneous panniculitis like T cell lymphomas. Subcutaneous, not cutaneous, then will come under there. Subcutaneous panniculitis like T cell lymphomas. Of this, I feel the most important for exam will be the enteropathy associated T cell lymphomas that will be asked under the heading of celiac disease. That's why, especially if the patient is not compliant to your gluten-free diet, the long-term result may be enteropathy associated T cell lymphoma. And nodal disease, number 1, typically you might be having peripheral T cell lymphoma, something called not otherwise specified, NOS. Second one, you have something called anaplastic large cell lymphoma, that's called ALCL, very important for exams, which will discuss what is the importance in this. And third one, you have something called an angioimmunoblastic T cell lymphoma. But the most important in this group will be the anaplastic large cell lymphoma. I told you one important disease in one entity. Here it is the primary, here it is the mycosis fungoides and Sézary important. Here it is the enteropathy associated T cell lymphoma. In this group, the ALCL is the most important, anaplastic large cell lymphoma. And the leukemic counterparts, you have a lot of leukemic diseases. Leukemic T cell neoplasms and NK cell neoplasms include, number 1, you have something called an adult T cell lymphoma leukemia. This is also called as ATCL, adult T cell lymphoma leukemia. Number 2, you have something called an aggressive NK cell leukemia. Aggressive NK cell leukemia. Then finally you have T cell pro-lymphocytic leukemia. Then finally you have something called large granular lymphocytic leukemia, otherwise called as LG leukemia or LGL syndrome, large granular lymphocytic leukemia or LGL leukemia. So these two are more important here. So what are the important things that you have to know for exams among the T cell is the mycosis fungoides and Sézary syndrome, enteropathy associated T cell lymphoma, anaplastic large cell lymphoma, and adult T cell lymphoma leukemia and large granular lymphocytic leukemia. These are some of the crunch points in exam that you have to know. So these are some of the important classifications of non-Hodgkin lymphoma. Hodgkin lymphoma I'll discuss separately in the next video, which is on Hodgkin lymphoma only, where you will have separate disease classification into something called your classic Hodgkin lymphoma and nodular lymphocyte predominant type of Hodgkin lymphoma. These are two important varieties in a Hodgkin lymphoma: classic Hodgkin lymphoma and a nodular lymphocyte predominant type, which are going to deal it extensively in the next video. But right now I've told only about the classification of non-Hodgkin lymphomas in general, B cell and T cell lymphomas. So now, what are the cell of origin? Because T cell, the T cell is the origin, but B cell lymphomas are going to be 85%, and not all these lymphomas are originating from a particular B cell. The B cell itself is undergoing through a lot of maturation process. And what is the exact site of origin of all these B cell lymphomas, including Hodgkin lymphoma? Let us see in this particular image. I have not told you much about this particular image. This is a hand-drawn one which I have drawn already before starting the session. But it's really important to understand where each and every lymphoma originates from. What is the cell of origin? So first let us name the cells. What could be the different type of cells here? So this I can call it as something called a naive B cell. This I can call it as a naive B cell, number one. So this is a naive B cell. So once you take it as a naive B cell, this I can tell something called a B1 B cell, that's called a CD5 positive B cell. So do you remember, I've already told you about the CD5 positive B cell, which is nothing but a B1 B cell. This is a fetal liver produced cell, CD5 positive B cell. Then next you have something called a germinal center B cell. So this B cell comes into the follicle and gives rise to something called a germinal center reaction. So this is called a germinal center B cell initially activated. So all these, whatever I'm going to draw germinal center B cell, the first one, these are the centroblasts that are typically proliferating B cells, which means they are activated and they are proliferating. And second one, there are centroblasts have two fates. The first fate, they can undergo selection process and they get selected. And the second type of centroblast, which I have discussed extensively in the last video, where the patients are going to have the lymphocytes are going to go for apoptosis, which means they are not selected. These are called as crippled lymphocytes, which means they will be destined to death, towards death only. They are not going to survive, which means they are not survived the selection process that is happening in the germinal center, which we discussed already in detail. The selected B cells, after the B cell selection, they can be having one of the two fates. Either they can become a plasmablast, which then becomes something called a plasma cell. Either they can become a plasmablast, or they can become a plasma cell, or they can become a memory B cell, or they can become a memory B cell. You all know that the zone that is surrounding this mantle zone tends to be dark. I told you already. These are cells that do not participate in the germinal center reaction. They are pushed outside. These are naive B cells only, and other B cells which are not going to participate in the germinal center reaction. We are going to call these cells as mantle cells. I told you already, these are nothing but mantle zone cells. And you also have a marginal zone B cell. So this is called a marginal zone B cell. This is called a marginal zone B cell. Marginal zone is usually seen only in the spleen. Remember, in normal adult or child patients, where you have the marginal zone is normally seen only in the spleen, but there can be marginal zone lymphomas also if that splenic marginal zone malignant cells, malignant B cells come into the blood and get deposited in the other areas. There can be nodal marginal zone B cell lymphomas also, but marginal zone, always remember, physiologically it is present in the spleen only. But why I have drawn with dotted lines here in this particular example, you can see here why I have drawn with dotted lines here is because I want to show the marginal zone here itself. That's why. So what are the cells of what are the cells of origin of different group of lymphomas? That's what we are going to see here. First, if you ask me, the CD5 positive B cell is going to give rise to something called a CLL. So which means it's an unmutated CLL. We'll discuss what is unmutated and mutated CLL. Characteristically, unmutated CLLs originate from this particular CD5 positive B cell only. Clear? So then you have this characteristic mantle zone B cells. These mantle zone B cells are going to give rise to something called a mantle cell lymphoma. Both you have to understand, because the CLL and mantle cell lymphoma only are very important to differentiate, which we'll see in the immunohistochemistry in some time, how to differentiate. And next thing, you can see a lot of these centroblasts that are proliferating. The centroblasts give rise to a lot of neoplasm. This proliferating B cells in the germinal center itself might result in a lot of neoplasms. Number one, it can give rise to aggressive types of neoplasm like DLBCL, that is diffuse large B cell lymphoma, especially of germinal center B cell type. So whenever I put DLBCL of GCB, means it's a germinal center B cell type of DLBCL. Number two, you can give rise to another aggressive neoplasm called primary mediastinal B cell lymphoma. This is another aggressive type of neoplasm called primary mediastinal B cell lymphoma. And the third aggressive type of neoplasm is Burkitt's lymphoma leukemia. Typically, Burkitt's lymphoma leukemia also originates from this centroblast and is going to be very aggressive. And it can lead to less aggressive tumors very rarely, like something called post-transplant lymphoproliferative disorder, or otherwise called as post-transplant lymphoma, or simply you can call it as post-transplant lymphoproliferative disorder, which is not that aggressive. And it can give rise to a lot of indolent lymphomas like follicular lymphoma also. Follicular lymphoma is one of the examples of indolent lymphomas. So that is also possible. So these are the different types of lymphomas that are possible. These three are very aggressive, and these two, these are not aggressive. This is, less likely to be aggressive, and they're mostly indolent group of neoplasms. So these are the ones that are going to be coming from this proliferating B cells, or simply we can call it as centroblasts. So now once the selection process complete, these cells typically are going to call as centrocytes, isn't it? These are selected cells. The moment the cells are selected, they will be called as centrocytes. But remember, centroblasts and centrocytes you should not call when a malignancy is formed already. These are just selected cells that are going for malignancy, or centrocytes going for malignancy. But once malignancy is formed, it's not called centrocyte malignancy or centroblast malignancy. You should not call that names and all. What are the tumors that probably originate from this? Selected cells, probably. That cells that are selected for further differentiation and proliferation. So number one, typically the characteristic tumor that you get is a Hodgkin lymphoma, typically of the nodular lymphocyte predominant. That's called NLP Hodgkin lymphoma, otherwise referred to as nodular lymphocyte predominant type of Hodgkin lymphoma, is going to arise from this centrocytes only, the selected cells only. The cells that are destined to go for apoptosis, this is going to give rise to one particular type of lymphoma, again a Hodgkin lymphoma, typically a classic Hodgkin lymphoma. I told you Hodgkin lymphoma is divided into two types, that is called a classic Hodgkin lymphoma and a nodular lymphocyte predominant type Hodgkin lymphoma. In that, the classic Hodgkin lymphoma is going to originate from this crippled B cell. Crippled B cell in the sense they are going to originate from this cells that are not selected, centroblasts that are not selected, and they are destined to go for apoptosis. And the selected centroblasts that are going to transform into centrocytes, if you get malignancy from those cells, that is going to give rise to something called nodular lymphocyte predominant type of Hodgkin lymphoma. And finally you have this marginal zone B cells. This marginal zone B cells will give rise to this marginal zone lymphoma, typically of the splenic marginal zone lymphoma type. Marginal zone lymphoma type. Clear? And finally you have this plasma blast. You can see here this plasma blasts have come. So what are the tumors that are going to originate from this plasmablast. From this plasmablast, you can have a lot of tumors. Typically, you will get a high aggressive variety of tumor called DLBCL, especially of ABC type, which means what do you mean by ABC, DLBCL? DLBCL of ABC we call it as activated B cell phenotype of DLBCL. There is a lot of variants of DLBCL are there. Number two, apart from this activated B cell DLBCL, that's called ABC DLBCL, you have something called a primary, another aggressive type called a primary effusion type of lymphoma. That also tends to originate from this particular cell only. And number three, one more neoplasm also can come from this plasmablast, that is called lymphoplasmacytic lymphoma. Typically, it leads to something called a Waldenstrom's macroglobulinemia. Waldenstrom's macroglobulinemia. That's called lymphoplasmacytoid lymphoma, which means the cells will be somewhere in between. They'll resemble lymphocytes also, they'll resemble plasma cells also. That's why it's called a lymphoplasmacytoid lymphoma. Then what are the neoplasms that can originate from the plasma cells? Plasma cell neoplasm is only one thing that you have to know, that is a multiple myeloma and probably a plasma cell leukemia. We'll discuss the differences later on. But very important thing I want to tell you about is the multiple myeloma, which is going to originate from the plasma cells only. Clear? So this is the only tumor. Remember always this plasma cell is a long-lived plasma cell. This type of activated plasma cells tend to be long-lived, and the plasma cells migrate to the bone marrow, and that's why multiple myeloma is a neoplasm of the bone marrow, not the lymph node. You have to always keep in mind about that. And finally, what are the lymphomas that can originate from this memory B cells? These memory B cells can give rise to CLL, mutated type. So mutated type of CLL can originate from this memory B cell. And another neoplasm called hairy cell leukemia. And third one, you have something called B cell prolymphocytic leukemia. B cell prolymphocytic leukemia. All these things are going to originate from this particular memory B cell only. So these are the cell of origins of different B cell neoplasms. T cell neoplasms, we don't have a particular cell of origin, but it's very important to understand. So these are the important cell of origin of a various B cell neoplasms. Anything can be a very important question in exam. So be very, very careful. So this is a very important nutshell and summary. Very important to know. Very, very important to know. And I cannot make it more simpler than this. It's a very easiest thing to understand. Clear? Okay. Now, morphologically, how will you classify the neoplasms? So when the pathology is put under HP, so if we are discussing about the HP wise, histopathological examination wise, you see the cell morphology and how you are going to classify them. Morphological wise, I can put the non-Hodgkin lymphomas and Hodgkin lymphomas. Like I'm going to put into, one is called monotonous variety, monotonous cell type, which means it's a homogeneous type. Monotonous means you are seeing a very homogeneous, like same type of cells you are seeing everywhere. There is no change in the nature at all. Then, or you are seeing a heterogeneous type. Or you are seeing a heterogeneous population, or you are seeing a pleomorphic population. Heterogeneous means not exactly same type of cells, but some cells will be a little different, but not very different. But pleomorphic will be so much different type of cells, small, large, big, very, very small, so many different types are there. That's called pleomorphic. And heterogeneous means different type of cells, but not that much varying. So monotonous means homogeneous, same type of cells. Whatever cell type you see, same thing will be there throughout the entire biopsy. Picture will be of the same type of monotonous repeating cells. So if it's a monotonous cells, you can split into neoplasms that have monotonous, homogeneous, only small cells. So typically you will see this kind of picture in a CLL or a SLL. You might see in a mantle cell lymphoma. You can see in a follicular lymphoma. You can see in a marginal zone lymphoma. You can see in a peripheral T cell or NK cell lymphoma. Peripheral T cell lymphoma or a peripheral NK cell lymphoma. Then you can see second group of cells. These are called as medium cells. Medium cells are characteristic of Burkitt's lymphoma usually. Burkitt's is characteristic of a medium cell lymphoma, medium size cells only. Then you can see in aggressive NK cell or T cell lymphomas. NK cell or aggressive NK cell, T cell lymphomas and leukemias, you can see medium type cells. Large cells, typically you will see in diffuse large B cell lymphoma, and there is another variety called plasmablastic lymphoma, which I have not discussed, but still just for understanding I'm writing plasmablastic lymphoma. But typically the name itself came diffuse large B cell lymphoma because the cells are large. That's why DLBCL is very important. Some type of this peripheral T cell, peripheral T or NK cell neoplasms may also be large in nature, but that is not important here. But the most important in the large cell will be the DLBCL, that is diffuse large B cell lymphomas. What about heterogeneous? Heterogeneous means there will be a mixture of different group of cells will be there, but predominantly what you will see. So if you see mainly small cells or mainly large cells, mainly small cells, but the picture is heterogeneous means it could be just a reactive hyperplasia of the lymph node, but you cannot be very sure. It could be just a reactive hyperplasia. Sometimes you can see in follicular lymphoma, because you can see follicular lymphoma is small, or it can come heterogeneously like typically predominantly small also. Then you can see in marginal zone lymphoma as usual. Then you can see in SLL and CLL as usual. Then you can see in a peripheral T cell neoplasms also, peripheral T cell lymphomas also, which means predominantly small again means they are going to become the same small. Sometimes it can be heterogeneous population depending on the proliferation rate, and they are also going to have mainly small. If you want to know mainly large cells, typically mainly large cells you can see in reactive immunoblastic proliferation. Again it could be reactive hyperplasia, where it's not just a reactive hyperplasia, it could be reactive immunoblastic proliferation. Sometimes other group of lymphomas may also have this reactive, but very importantly, because since the topic we are discussing on Hodgkin lymphoma, remember one other entity which will come as heterogeneous but mainly large cells is classic Hodgkin lymphoma. This classic Hodgkin lymphoma also tends to be typically large cells but more heterogeneous than homogeneous and monotonous. Then you can see on the pleomorphic cells also. What are the areas where you see these pleomorphic cells? Most importantly, you will see in anaplastic large cell lymphoma. That's always referred to something called ALCL. And then you have the lymphocyte depleted type of Hodgkin lymphoma. That should not be actually coming under this NHL classification. So I'm putting a division here. So you have this lymphocyte depleted type of Hodgkin lymphoma. So remember, this is the general morphological classification given by any pathologist. So this is what happens. This is how we differentiate morphologically between like monotonous, heterogeneous, and pleomorphic. So pleomorphic means all groups will be there. It's not like you will have only one particular, predominantly small, large, everything will be intermixed, and you cannot really characterize which is predominantly small or predominantly large, or only small or only large. So remember, monotonous, small, all these are important to understand. All these will be small and monotonous. Large is very important again. And characteristic example of medium is something called a Burkitt's lymphoma. And mainly small means the same thing, you can write it again here, mainly small with an addition of reactive hyperplasia. And mainly large means you can write again a reactive immunoblastic proliferation. Apart from that, your classic Hodgkin lymphoma also will be having heterogeneous, predominantly large group of cells only. And pleomorphic in exam, if they tell you, the word pleomorphic they give always goes towards anaplastic large cell lymphoma only, which means lot of cell group types will be admixed with each other. So this is pleomorphic. And you think whether this type of classification really is confirmatory for some lymphoma? They can suggest the presence of a lymphoma, but morphology wise in histopathology examination they can never confirm a lymphoma, or they cannot never confirm a type of lymphoma, which means you cannot even suggest management based on this. So definitely you need to do IHC and cytogenetics for sure, especially if it's a non-Hodgkin lymphoma. Cytogenetics play a very, very important role, and immunohistochemistry plays a very, very, very important role. So now in general, as a lymphoma, how will you classify by IHC? By immunohistochemistry and CD marker typing. IHC means we are going to use the CD markers for characterization. If you use the CD markers by IHC, how you are going to classify a lymphoma. This is a very important topic to understand. So first one, algorithm wise, let us see you are suspecting a lymphoma. Patient is having, probably I can write here, patient is having a suspected lymphoma. Right here because I don't want to write there. So patient is having a suspected lymphoma. So in this condition, see whether you are seeing a predominantly large cells morphologically or predominantly small cells, predominantly small or medium cells morphologically, small or medium sized cells morphologically, predominantly. So if you are seeing predominantly large cells, do CD45 first. CD45 will be the first step to do. If CD45 can be positive or CD45 can be negative. If CD45 is positive, then you do CD20 testing. That's what we do next. If CD45 is negative, you can do CD15 and CD30 testing. CD30 testing. If CD20 is positive, if now CD20 is positive or CD20 is negative, remember it's unlikely to be a B cell neoplasm. CD20 is negative and CD45 is positive. So see CD3, usually CD3 will be positive and it generally goes towards a T cell neoplasm. So T cell neoplasm are generally rare, it generally goes towards a T cell neoplasm. If CD20 is positive, then do CD5 testing, which is very, very important. The moment CD20 is positive, if CD5 testing comes positive or CD5 testing comes negative, if CD5 testing comes negative, it typically goes towards a DLBCL. Very important. CD5 negative always goes towards a DLBCL. If CD5 is positive, it typically goes towards a blastoid mantle cell lymphoma. Remember, in a mantle cell lymphoma, usually it will be a small cell only. I told you already, you can see the morphological classification. If a large cell but mantle cell phenotype. Mantle cell means CD5, CD23 will be also positive, but I didn't discuss about that. But CD5 positive here, CD20 positive here usually goes towards a mantle cell lymphoma. I mean, in this condition, since it's a large cell, we are going to call it as a blastoid mantle cell. Now see if CD15 or 30 are positive. If CD15 or 30 is positive, it typically goes towards a classic Hodgkin lymphoma. Classic Hodgkin lymphoma. If CD15 or 30 is negative, CD15 and 30 is negative, it goes towards other lymphoid malignancies. You have to screen more, but in exam it is not important. This much is enough. So then we move on to the small or medium cells algorithm. If you see a small or medium cell, the first thing you have to do is again CD20, not CD45 in this case. You do a CD20 in this case. If CD20 is positive or CD20 is negative. Having a small, predominantly small group of cells and having a CD20 negativity is very rare, to be honest. If CD20 is negative, then you see the CD3, just see CD3. Usually many times it will be positive. Small cell CD20 negative means usually it will be a T cell neoplasm. And so that's why I'm writing CD3 positive is a marker of pan T cell marker. So I'm going to call it a T cell lymphoma or a neoplasm. CD20 positive is a big thing because small cell CD20 positive, so many things are there. Now next step, as usual, see CD5 positive. After CD20 it's CD5 only as per the stepwise manner. If CD5 is positive or CD5 is negative, if CD5 is positive, next step is to see CD23. Very important, why I'll tell you, because if CD23 is positive or CD23 is negative, if CD23 is positive, it typically goes towards a CLL or SLL. If CD23 is negative, it goes towards a mantle cell lymphoma, classic mantle cell, not a blastoid variety. Classic mantle cell lymphoma will be CD5 positive and CD23 negative. Very important for exams. CD5 positive, CD23 negative, mantle cell lymphoma. CD5 positive, CD23 positive, it is CLL, that's it. Finish. This is something gold standard to know. You cannot afford to forget this. Then if CD5 is negative, for example, then you have to do CD10 and BCL6. This has to be done, CDL10 and BCL6. If CD10 and BCL6 positive or CD10 BCL6 negative, if CD10 is also referred to as something called KALA. You have to know that point also. I didn't tell you, I think, in the basics. CD10 is also called as KALA. That's called common ALL antigen. Very important. One of the first antigens to be discovered in ALL. That's called a common ALL antigen, CD10, otherwise called as KALA. If CD10 BCL6 positive means then you have to do BCL2 testing. If BCL2 comes positive, then it generally goes towards a follicular lymphoma. BCL2 is also positive, it generally goes towards a follicular lymphoma. If BCL2 is negative, it goes towards a Burkitt's lymphoma. Burkitt's lymphoma or a leukemia. Remember, BCL2 positivity is very important for follicular and Burkitt's. Please never forget that BCL2 positivity, BCL6 positivity is very important for a Burkitt's and a follicular lymphoma. But remember, Burkitt's is typically BCL2 negative. Only follicular will be BCL2 positive. Very important point. Remember, Burkitt's will be BCL2 negative, but BCL6 positivity is very important for a follicular and a Burkitt's. Then if BCL6 is negative, then you can do other markers like CD25, CD103 and all. The CD103, why I am doing very well, because it's a very important marker of a neoplasm called hairy cell leukemia. Very important actually. That's why I am doing the CD25 and CD103. If CD25 and 103 is positive, it's very likely to be a hairy cell leukemia, because the CD103 very common in exams, they will ask you. It's very important, like how you do CD1A for Langerhans cells. Similarly, the CD103 in exam is a very stereotypical question. If they give CD103 positive, go for hairy cell leukemia. Hairy cell leukemia. And if CD25 and CD103 is negative, then you can do CD43 testing. It's a very important marker. CD43 is a marker of marginal zone cells. Very important, which I have discussed already. So if CD43 is positive, it goes typically towards a marginal zone lymphoma. Marginal zone lymphoma. So if CD43 is negative, then you can go for lymphoplasmacytoid lymphoma. Lymphoplasmacytoid lymphoma or lymphoplasmacytic lymphoma. That's what CD43 negativity means. So this is the entire algorithm. I told you here CD3 positivity here. Somewhere I told you, CD3 positive T cell neoplasms. One more thing also you have to remember. So if CD3 is negative, for example, let us assume if CD3 I have done positive, I told you, but what if CD3 is negative in the same algorithm, like CD20 negative, at the same time CD3 is also negative, means one important neoplasm you are missing out, which means a plasma cell neoplasm. I told you plasma cell neoplasm will not have CD20, they will lose the CD20, very important point. And they will not have CD3 also, because it's not a T cell lineage. So in a plasma cell neoplasm, CD20 will be negative. So you have to do the CD38, CD138 and all, and MUM1 and all you have to do, MUM1, all these things. Usually it will be positive in case of a plasma cell neoplasm. But very importantly in exam, plasma cell dyscrasia or like a multiple myeloma, plasma cell neoplasm, usually they will give the CD138 only. I again told you multiple times while discussing about the basics of the B cells. The first video of the basics of the B cells, I have discussed a lot on CD138. Very important point. CD138 positivity in exam, it means it's a plasma cell dyscrasia or a plasma cell neoplasm. Very important point. So this is the entire algorithmic classification of how we approach a lymphoma through IHC. In this certain important points, if you want to know, so sir, this is very difficult for me to understand and comprehend. I need much simpler version of all this, if you ask me. Then you can remember this very important thing. I told you already, this CD23 negative, CD5 positive mantle cell lymphoma, and CD5 positive and CD23 positive goes towards the CLL. This is really important. This is multiple times asked. Similarly, this BCL6 positivity in follicular and Burkitt's, and BCL2 negativity in a Burkitt's, again many times asked. Similarly, the CD103 positivity in hairy cell leukemia, and CD138 positivity in a plasma cell dyscrasia. All these things are very, very important things to be known. And the CD1530 positivity in a classic variety, I'm not talking about nodular lymphocyte predominant, in a classic Hodgkin lymphoma, CD15 and 30 will be positive, and again it's very important to understand. Clear? So these are some of the important points. CD1530 positivity in a classic Hodgkin disease, CD5 positive and CD23 positive in a CLL/SL, CD5 positive and CD23 negative in case of a mantle cell lymphoma, CD103 positive in case of a hairy cell leukemia, and CD138 positivity in case of a plasma cell neoplasm like multiple myeloma typically. And finally, one other thing, that BCL 6 positivity in case of both follicular and Burkitt's, whereas BCL2 will be negative in case of a Burkitt's, whereas BCL2 will be positive in case of a follicular. This is the most important among all the CD markers. I have tried to simplify these markers as much as possible, and that's why I told you this basics of this lymphoma video is really important for you to understand. So with this, we are finishing off with the basics of the lymphoma. In the next video, we'll be seeing on Hodgkin lymphoma, and in the subsequent videos we'll be discussing on the other types of lymphomas, including non-Hodgkin, plasma cell dyscrasias, myeloproliferative neoplasms, myelodysplastic syndromes. There are so much to come. See you.